All right. Well, welcome everyone to Pregnancy, Birth, and Beyond. This is the second event series of the topic actually at hand. We'll be talking about the benefits of having a PT and an OT when it comes to mental health with our maternal population. And I have a very, very, very exciting panel. I'm just really excited about who we have in the room. And I'm going to actually really open up the floor so that they all can introduce themselves. But we're going to actually go around and talk about this important topic that I think is beyond timely when it comes to maternal mental health. We're now looking at latest statistics that recognize that suicide is the leading cause of death in the first year after birth. And I want you all to really sit on that and think about that. And so we were focused a lot on cardiovascular health in our maternal population, especially as it affects Black and Brown mothers. We're very focused a lot on hypertensive disorders. We do not talk about mental health to the extent that it needs to be discussed, especially within the first 6 weeks of birth. And so I have on this panel with me a group of dedicated physical and occupational therapists. We have one occupational therapist that's holding down the fort. And I would really like to start with Simone Allen. Simone, will you introduce yourself tonight?
Hi, everyone. Rebecca, thank you for having me. My name is Simone Allen, and I am an occupational therapist in New York City. I have been working in the mental health field for over 10 years, starting with inpatient psychiatry. And for the last 2.5 years, almost 3 years, I have been working with an organization in a community-based setting where occupational therapy services are provided to survivors of domestic and intimate partner violence, individuals with disabilities and those without disabilities as well. So providing support to those survivors from a mental health perspective, but also from a physical perspective, depending on any disabilities or challenges that they may have.
Beautiful, beautiful. Dr. Middlebrooks, welcome.
Awesome. Thank you so much for having me. I'm very excited to be a part of this. This is wonderful. My name is Dr. Dionnne Middlebrooks. I'm a physical therapist, and I'm also an orthopedic clinical specialist. I work a lot with pregnant and postpartum women. I'm a public health therapist. So I do see women as early as 2 weeks following the birth and delivery of their babies. I do give the option as to whether or not with the system itself automatically prompts saying, hey, do you feel like you need extra additional support at this time prior to those 2 weeks? That way, if they feel like they need that support, they're able to reach out to me directly. And if I'm able to help, I can. If not, I'm able to get them in contact with the appropriate individuals. I have found myself working with postpartum women because of one, my own experiences. I do have 3 kids. And then also because of just a disparity that was present just as a whole, especially underserved communities. And then with my fitness background, there were a lot of moms that were not receiving proper care and the appropriate information as well, which was directly affecting their recovery and return to activities and ultimately affecting their mental health as well. So that's a little bit about me. So I'm located in the metropolitan area of Atlanta, specifically Stockbridge.
Excellent. Thank you. Thank you so much for joining us. Dr. Shiroz.
Hello. Very similar to Dr. Dionnne. I am a pelvic floor physical therapist. Dr. Shiroz Arian, I'll say it for y'all because sometimes it can be a little intimidating. Located in Huntsville, Alabama, treating postpartum, peripartum individuals, but same type of reason why I got into it was because as I was treating these individuals and seeing the providers that they were talking to and the things that they were just not getting the education on and providing that information, and they're just like, no one told me this, and does this seem normal, or is this something that I need to wait on, or is this something that will change? And so having that background and being able to provide that to people, but also working with local birth workers, doulas, midwives, and just working with them and explaining to them the ways that they can help these pregnant individuals and help them with postpartum care.
Excellent. Thank you so much for joining us. We're gonna move to Texas, still in the South. Dr. Lokati, thank you so much for being here. Please introduce yourself.
Thank you for having me. So my name's Erin Lakati. I'm a pelvic physical therapist that works in acute care. So I actually work in a hospital in San Antonio, Texas. I see high-risk antepartum patients who are admitted to the hospital. And then I also work with postpartum patients kind of 24 to 48 hours after delivery while they're still in the hospital before they go home. So similar to Dr. Middlebrooks, right? I really got interested in this after I had my own kids and was really struck by just the incredible lack of information that was available, even as somebody who worked in healthcare myself, how little even I knew about how to recover well functionally and what was normal and what was not normal. And that's when I started moving into this space.
Excellent. Thank you so much for being here. And Anjali, thank you so much. Also from Texas.
Also from Texas. I'm from Houston. Thank you guys for inviting me. I am probably the lone wolf here. I am a NICU PT. So I'm very excited to be part of this conversation because I think that definitely when I started taking pelvic health classes, I realized for like 10 years, I've missed the boat completely on the other half of this baby. And so that was quite, like a stab in the heart. But anyway, we're here to fix all that. So I'm very excited to partner with everyone here tonight.
Excellent. Awesome. Well, everyone, thank you so much. I've been allowing really people to filter into the room. And this time I will, for the sake of our viewers, you won't be able to see the engagement that might be happening in the chat, but occasionally I would like to bring someone from the attendee side up on stage to join us in this conversation. So I really want to have a conversation with you all tonight. My name is Rebecca Seagreaves. For those of you who do not know me, I worked in outpatient pelvic health and did a lot on the oncology side and almost burned out within 2 years of finishing my PT schooling and residency training in women's health. And the reason why I almost burned out was because of the fact that I didn't go into PT to be reactive. I never thought that I would be waiting until someone developed an issue to treat it. I was very much a preventative. I was a personal trainer. So Dr. Middlebrooks, your background in fitness, I'm just like jiving with you now. Because of that, I found myself taking a very unique position to work with individuals in the hospital after pelvic health surgery and birth. So I'm going to tell you a story, and I really want us to have a conversation about this particular circumstance and why, to me, what we do earlier rather than later affects mental health so profoundly when we are talking about the maternal population specifically. So I was in the hospital. Again, that's not my background, but I took a job inpatient where I was able to help start a program that offered automatic physical therapy services to moms specifically after cesarean section. Before that even happened, though, there was a long road to get to that point. So I was pushing for orders for this particular individual who was already up and walking, which most people who know acute care physical therapy, if you're already up and walking in the room, Erin, you're shaking your head, likely you're fine, you're discharged. Like, we see people who really need us. We don't necessarily think preventative in that regard. But I was pushing for orders with this particular individual. First of all, her cesarean section, we've heard this before, was unexpected, right? And so we could talk about all the things around an unexpected C-section. Been pushing, been in labor, baby doesn't descend anymore. They're like, we need to get this baby out, right? She had already been in the hospital by day 3. So doctors weren't really happy that I wanted to see her, right? I was holding up orders for discharge. So I saw her and I did what I typically did with anyone after cesarean section. And for those of you who are like, what would you have done in the hospital setting? Well, I saw that she had been sitting up in bed for the entirety of her hospital stay, which is 3 days. Anyone who knows a C-section, you could feel right now on yourself is that area where that incision is right in the crease of your hip, right? And so I want you to imagine someone who has been sleeping like that, who's been feeding their baby like that, who has been eating their meals like that for 3 days. So not one person told her, might want to lie flat and stretch out. And so I didn't see that she was in pain. I didn't see that she was, necessarily in such distress that would have necessitated my services. I just saw this as an opportunity to teach her how to get in and out of her own bed because I knew she wasn't going to have a hospital bed. So when I did that, the amount of relief that crossed this woman's face, I will never forget. And to my surprise, she started to cry. And before I could ask, why are you crying? She said, why didn't anyone tell me this? And it was one of those moments where I knew when she started to cry, it wasn't because she was in more pain, and it wasn't also because she was in great relief. It was what she told me. She was disappointed that she had been suffering silently because she wasn't very vocal. There was no reason other than my persistence of getting that order that I was in her room. Other than that, she could have gone home and she would have been doing all of it on her own, like we expect people to do after a major abdominal surgery. Actually, after a C-section, we actually provide services after other abdominal surgeries. So I tell this story to you now because that probably was the biggest eye-opening moment that I had, that this affects mental health when we either withhold information, not intentionally, but we have professionals in our hospital settings that can make a difference in someone's recovery. And it affects their mental health when they are suffering in silence because they think it's normal, especially after a primary C-section. You're told by everyone, yeah, it's going to be hard. But if we have the opportunity to change that as therapists, then why don't we? But then also, why don't we educate more people about what we could do, even if we're not there yet? I don't care that all of you are not in the hospital seeing moms after birth, but I want to have a conversation. I want to have it now. So after hearing that, Dr. Middlebrooks, you be in my shoes as an outpatient therapist. I'm in the hospital now. I'm not an acute care therapist. What would you have done in that moment that would have probably changed that woman's life 3 weeks down the road when she is by herself, maybe with a toddler? If it was a primary C-section, I remember this one case, she did have a vaginal delivery before, and this was an unexpected C-section. So tell me, as a mother of 3, as a physical therapist, fitness background, what would you have done?
First and foremost, say it's going to be okay. A lot of times we are constantly in a rush, especially as medical providers, because you're always thinking, I got to do this, I have to do that, I have to go see this person. But I'm guilty of it as well. We need to slow down and we actually need to see the person in front of us and just say, hey, it's going to be okay. It would have been nice had she had services prior to that, like leading up, just in case, so that she would have been educated, hey, things may not go according to plan. And even though things did not go according to her plan, still letting her know it's still going to be okay. I definitely would have done the bed mobility things with her. I definitely would have tried to get her up and moving, especially because, yeah, she just had a major abdominal surgery. In addition to that, with her laboring for who knows how long prior to that, we already had various blood changes itself, including especially platelets as well. So she's at risk for blood clots. I need to make sure that she is moving. I need to make sure that she is getting the care that she needs in that aspect. Hey, if you haven't been moving, something as simple, let's get you in some TED hose. Are you noticing any pain? Here are the different things I need for you to be aware of. Let me educate you on the signs of infection. And all this information can be overwhelming. However, it is so very important and this is not a shot against physicians, but unfortunately, the surgeons come in and say, this is to be expected. You're going to be hurting. It's going to be red. But there's a difference between having pain from a surgery with redness and having pain that's caused from an infection. There's a difference between having that type of pain and having pain that's caused from a DVT. So I really want for her to understand, yes, this is what you're saying. This is what I'm thinking. These are the different signs I want you to be aware of, because my goal is to help you get to a point to where you're able to do things you need to do when you get home. And most importantly, you're not just taking care of yourself now, you're also taking care of another human being. So if you're not well, that baby's not going to be well. And that's so very important that we're able to educate people on that. And then saying, hey, do you have support going home? Even if the only support I can give them is another public health therapist, at least that person can put them in contact. At least I can say, hey, this person, contact them. They'll help guide you with the next steps. So I'm an outpatient, so my it's a little different, but had I been in that situation in an acute care, those are just some different things I would have, I definitely would have addressed. And I'm sure I would have overwhelmed her. I would have given her so much information, but I also would have wanted her to know, that, hey, it's okay. I care. If you have questions, this is how you find me. And that's just one thing. People just want to know that you're available to answer questions if they need you at a later date as well.
Dr. Middlebrooks, you would have had 72 hours with this person. So when we talk about everything that she just said, everybody understand. No, you're not going to say it in 15 minutes. You're not going to say it in 15 minutes. You don't even have to say it in one visit. You can have more than one visit when people are in the hospital. Simone, you have had experience in the inpatient environment. You have had experience with people who have been in an institution that is not their home. That in and of itself, what does that do mentally to someone? Then on top of just pain, function changes, just not being able to connect with their body, like what does that do to someone's mental health?
So, and I have no experience with maternal health, but during my experience, during the years that I was at the hospital, 95% of the patients who were admitted did not want to be there. Length of stay ranged from 2 days to, we had patients who were there for more than 6 months at different times. And when patients initially came in, they were very frustrated, they were very angry. They were usually brought in against their will. So, we usually face an uphill battle in trying to connect with them and establish that therapeutic relationship with them. It took time. And for the most part, we did have that we had that on our side, I would say, to connect with patients. Sometimes within the first 72 hours that they were there, they might have been medicated, which had an impact on us being able to perform any screenings or any initial evaluations that we might have done. But we were able to establish a therapeutic relationship, introduce them to the different services that OT provided on an inpatient unit, worked with the team as well to provide them with as much support as they would need.
Simone, I love that you're actually given this background, because I need people to understand that I have had encounter after encounter with mothers who have said, I felt like I was forced in the C-section. I felt like my birth was not my birth. I felt like I had no control. I felt like as soon as I was in here, they were putting IVs in me. So when you talk about an inpatient setting where people were forced against their will to be there, and you had to establish a therapeutic relationship, half the time, I always tell the good story, right? Of like what I did that made it better. Half the time, a lot of people did not want me in their room. They thought I was coming in and pushing down on their belly like the nurse was doing. And those of you who don't understand why they do that, they have to make sure that uterus is toned, is firm, so that we don't have people dying from postpartum hemorrhage. And so if you need more information and background as to why we're talking about these nuances around the birthing and postpartum period of, between the first 3 days and the first 6 weeks, it's very important that you know that the procedures that are done in the hospital, right, can help or hurt when it comes to recovery, physically and mentally. So Simone, I don't ask you or anyone to be on this panel because you have expertise in maternal health services. I ask you to be on this panel because I want to make sense of a system that doesn't include someone's mental and physical recovery after such an unexpected change in their life and function. And so if anyone can speak to not working directly with moms in the hospital setting, but actually working with their babies in the NICU, I'd ask Anjali, because she does not identify as a women's health physical therapist, but she identifies as someone who has to take care of her patient's caregiver. And that's that mom who just had a C-section, who's sitting up in an upright chair, waiting to know that their baby is okay, but no one's asking about them. So Anjali, can you speak to that? What have you seen that is so impactful on this person's mental health, who has to then come home and take care of their baby who was in the NICU?
Right. So I think we have two groups of women, right, that we in the NICU have to consider. So we have those moms that we know have been on prolonged bed rest with all the tocolytics under the sun, and they're being told, well, you need to go see your baby, which may be in the same building or in our case, or maybe like, across the street. And so those moms, they don't know which way is up. And the nurse is like, oh, your baby is eating this and doing that. And you just like, they're shut down. There's nothing, they can't enjoy their baby. Their baby's all like hooked up to everything under the sun. Nobody wants that for their baby. And you're expecting, a normal term, regular child. And now nobody asked you, did you want to have a preemie? Nobody asked you, did you want to have a sick preemie? Nobody's asking you, okay, well, we just ripped you from head to toe to get this kid out. You almost died. And now could you hurry up and make these life-saving decisions for your baby? Meanwhile, the other parent is freaking out because they almost lost both people, right? So that's one group of moms that I feel like we don't do a good job. And then we have the other that are the walking wounded, right? So they may have had the unexpected C-section, or maybe, it was that situation where the baby got stuck and now you have an HIE baby. You did have a term baby. You did have what was supposed to be a normal delivery, and then it all went sideways. And now again, we're asking you to make all these decisions. You can't figure out which way is up. And I mean, it is intense sometimes when you're down there and these doctors are like, right now, you decide, blah, But also there's the flip side, is that we have moms that have physical disabilities. And I have a lot of experience. And so I don't mind going up to a mom and saying, I see you have a walker and you are a spinal cord injury. Can I help you? We don't have those conversations. And I think we get kind of pigeonholed, and so you forget. So those of you that don't work in the NICU, maybe just have that conversation with your NICU providers, be it PT or OT, it doesn't matter, just to say, hey, my patient's baby is coming to your NICU. This is what she had. Do you think you could help her out? Because, in the NICU, we don't know. We don't know what happened to that mom, and especially if that baby came from an outside hospital. If we read an op report, it doesn't sound gory. It doesn't sound tragic. It doesn't, it just says, okay, C-section, this, that, and the other, but it doesn't tell you the whole part before, where, she labored for 22 hours before that, and whatever. So those are some considerations for us. And as I've been working with Rebecca, I've been taking it back to the NICU therapist saying, we need to step it up. So it's a work in progress. It's ever evolving. So I really do appreciate the opportunity to work with you guys on this.
Dr. Shiroz, you, I think, are the only one on this panel, I guess, in addition to the services I provide, you're in the home. You're actually going to people's home. And as much as I love talking about like what should be done in the hospital setting, before they can even get to Dr. Middlebrooks, an outpatient, right? That gap period is where I'm scared the most. And Erin is shaking her head because she's probably seen the readmissions. Over 50% of our moms are passing away within the first 42 days. That's 6 weeks, y'all. So Dr. Sharose, how do you feel like providing home care is probably more important than ever before, especially for that mental health aspect of just not having to find your clinic, get transportation, get somebody to care for babies, toddlers at home? How have you found that makes a world of a difference for moms?
Exactly. When you talk about traffic and other kids and childcare and that type of stuff, in those first weeks, even we know past the 6 weeks, you're still kind of underwater. But in those first few weeks, you're just like, I don't even know how to shower, let alone get to a certain location and then travel with this baby who may not like to be in a car seat. So being in their home, it just eases things. It puts you in your environment. You're not uncomfortable. You don't have to worry about how the baby is going to handle noise, or if there's going to be a place that you're going to be able to nurse the baby if you need to. You understand that you have your equipment, you have your things. And even from a physical therapy standpoint, I can now target my treatments to your environment. And so you can be more comfortable, you can be more forthcoming. You might not, if I'm, are you really using a boppy every time? Do you really have the support you need? Well, maybe not, because I see you over there, you're kind of slumped a little bit when you're nursing that baby. How can we adjust that? So it really just provides that level of comfort that when we're talking about mental health, when we're talking about a barrier to providing it, a comfort and education in your own environment really just does so much to then bridge that gap. So then at that 6 weeks, when you're at that outpatient standpoint, you've already done so much of the work that then it's easier to be more forthcoming and easier to be more comfortable.
Now, Dr. Licati, you and I have talked about this. I talk a lot about cesarean sections. 2/3 of births, though, are occurring vaginally, right? And so when we're talking about just what Dr. Sharose was telling, just that ease that people just feel when they don't have to go anywhere, what would you say, especially to our audience who is like mind blown should be right now, because they're like, wait, I could have had one of you in the room. What do you say right now is the biggest barrier to providing our services? And then I'm going to actually kick it right back to Simone, because as an occupational therapist, I know you have a lot to say about providing that holistic care, no matter who the person is, no matter what they've experienced. So it's not about whether or not you have the experience to treat somebody who just gave birth. It's about whether or not you see them as the whole person that they are. That's where I really want to start this conversation off. So Dr. Licati, how do you feel at this point is a barrier that we're facing that is stopping us from providing your services after birth?
Yeah, I just want to say, I love what everybody here is saying. I feel like I resonate with something everyone here has said. But with barriers to having a PT or OT go see somebody in the hospital setting, whether it's antepartum or postpartum, what I run into the most is people just don't know that that's a thing that exists or that's a thing that can be done. So that happens on the provider end with the people who are kind of your gatekeepers to getting therapy orders. So OBGYNs and also nurses. Nurses are a really big driver of orders in the hospital setting, right? If a nurse asks a doctor for an order, the doctor's just going to say yes. But they don't even know that therapy could possibly be coming to see them. I've had postpartum nurses, after I started going to their units, say, I can't believe you guys have been working in this hospital the whole time I have. I've sent moms home that had foot drop and were fall wrists, and I didn't even know that there was anything I could do for them, right? I just told them, well, be careful. And, we could have gotten them a walker. We could have had y'all come see them. I just didn't even know it was an option. They just didn't have any idea what therapists actually do and how that could fit in to their unit. And then the second big issue I run into is with other therapists, that there's a real sense of uneasiness about seeing the pregnant and the postpartum population, because we just really do not get education in that in school. We kind of just skip this incredible event that happens to a huge percentage of the population and has pretty significant physiological implications. We just don't talk about it in school. We don't really talk about the pelvic floor. I had to memorize all the muscles in the body except for those. We just kind of skipped that little chunk in the middle there. And especially in acute care, pelvic PT is seen as really being an outpatient specialty. So I find that a lot of my colleagues, just even when they're very capable therapists, very experienced therapists, they really know their stuff. When it comes to the pregnant and postpartum population, they feel like a new grad, and they're very scared and very hesitant to see them, and they just don't feel confident with providing care, and they're worried about doing harm by doing something that is going to make somebody worse postpartum or induce labor if they're still pregnant, or just not being able to answer a patient's questions that are related to postpartum recovery.
I don't have a problem with people not knowing what I do. I think I struggle with people already having it in their head what I do, and they're just like stuck there, right? It's a big difference, right? And so Simone, as an occupational therapist, tell me the truth. Have people asked, like, what do you do? What is that?
Usually I'll get, are you going to help me find a job? Because there's the occupational part of, what I do. So it's usually like, well, I don't really need help finding a job. And then I'll have to provide education on exactly what my role is and how I can be of service to them. I did just think about, though, because as I mentioned, I do consult with a nonprofit organization here in New York City. And one of the programs that I work at is a crisis shelter for, women or survivors of intimate partner violence. And, some of the interns that I have supervised over the last few years have had the opportunity to work with moms who do come to the shelter, whether they have one or more children, or if they are pregnant, or maybe experiencing some difficulty, with managing, their children after they've been discharged from the hospital. Typically what happens in the shelter, though, is OT is not the first service that they'll be educated on. So we'll usually get a referral from one of the other clinicians, whether that be a social worker, or sometimes the nurse who's on site will say, this resident came in, I noticed that they're having difficulty with this, and this, can OT go and see them? The great thing about the shelter, though, is that each family or each individual has their own unit. So we have the opportunity to go upstairs, be in the natural environment, even though it is a temporary one, and, work with the client and figure out, like, what is it that they need, what support they need, whether that is emotional support, if they need education on proper positioning, or if we need to refer them out to other services as well. So I wanted to just add that piece, because as I'm hearing everyone else speak, I just wanted to reflect on that.
I want to play a little bit of a game, right, with you all, okay? And I'm going to actually ask for anyone in who's an attendee to participate in the chat. Based on Simone, you're up first, but I'm going to have people just answer as you're answering, or you're either validating, right? I want to understand, first of all, occupations, what those might be after someone gives birth, right? And so, Simone, without you telling everyone, I'm just going to start naming things that acute care therapists would see, or that nurses would see, or whatever. And we're going to actually just play a game. So everyone in the attendees in the chat, what I want you to do is decide whether or not this is what an OT would address, what a PT would address, what a lactation support person would address, a doula, or the nurse, or whoever. We're just going to start naming things. So standing at the sink, brushing your teeth after blood loss that just has made you dizzy. Who would help in the hospital with that? Would it be a nurse, PT, an OT, a lactation person, a doula? someone who is standing at the sink trying to just brush their teeth, maybe do their hair a little bit, they can't hardly stay there because they feel so woozy after losing blood. Who would that be? I'm looking at the chat. No one yet. We're all stumped. Simone, don't say anything. All right, speakers. What do you guys think? All in mic.
Everyone.
Yes.
Everyone.
Exactly what I was
About to
thinking,
say
everybody.
Everybody.
You know, it's so funny. It's so funny. So you are like, duh. I bet the people that are going to be viewing this later, they really don't know. If they don't know what you know, how are we helping anyone? Fine. Same kind of scenario, but this time I've had a C-section. I need to sit down in a shower. There is just no way I could stand up. It hurts too much to stretch. No one's told me to lie flat. It is day 3. I'm taking my first shower. I need to sit the whole time. After I get clean, I can go home. Who might help in that situation? Looking at the chat. I'm trying to give our audience a little bit of time. All right, go ahead and unmic. Go ahead. Who might help in that situation?
In all honesty, everyone should be able to help it to some extent.
Really?
Not to the fullest extent.
When
but
you
to some
say
extent.
everyone, tell me who everyone is. Is that the caregiver? Is that the partners, other parent? Like who are we talking about? Who's everyone?
Everyone no, but no, the caregivers, whatever medical providers are there, if there's a doula there, they should be able to, like patient consultant, OT, PT, nursing, everyone plays a role. So you may not have the most knowledge, but the biggest thing is that individual safety and based upon, of course, your comfort level. If you're not comfortable, there's nothing wrong with you saying, hey, I need help, especially if you're already in that hospital setting, but you can at least begin to address the situation. The biggest thing that I've seen is that most people they're afraid to speak up. They're afraid to say, I need something, especially in the hospital. I don't want to be the one to bother someone. So to an extent, everyone can play a role with helping. Now, are they going to be able to help to the same capacity? No, but everyone can help to some extent.
I 100% agree. I feel like, you know, when you're talking about in the shower, nursing has their component of how you should be showering or even assisting you with that. But then, you know, you have your physical therapist, occupational therapist, and the best ways to do it and complete it and looking at the body mechanics of it. Your doula could be education even of ways to protect your body because they have that knowledge too. So I think everyone has a component to it. While it might not be the same component and it may be graded and you may at some point pass off to the next provider, but everyone does have their part.
Okay, a little bit harder scenario. This is actually a real case I had to be involved with. Mom has no support whatsoever. Has to go to work, wants to go to work. Within 2 weeks, had an unexpected C-section. Baby couldn't empty his bladder, so it's brought to the NICU. All she's thinking about is the list of things that she has to do and the fact that she has to drive herself home because she drove herself to the hospital. She has steps that she needs to get up, has to carry the baby. Who helps in that situation? Don't say everyone. I want now to know, I want roles to be broken up because if we say everyone, then it's the nurse's job. And that's where we're right where we could just be talking in circles because then the nurse is going to be like, I can't do all of this. And so it doesn't get done. She gets sent home. So who can help in this situation? I'm looking at the chat.
First thing okay, want me to say anything or get them go in the chat?
Anjali, I'm going to pick on you. On Mike, you were red the whole time.
Oh, well.
Mike was on the whole time.
Yeah, my situation is a little unique. So I would say certainly a NICU therapist can talk to this mom about what's the best way. Do you take the baby in a carrier? You know, you have lifting restrictions, which I will tell you, most mothers are not educated on. So when they come to the NICU and you've got this baby, well, I digress. But yeah, so I would say that's where we could jump in and help. Like, what are good tearing techniques? How do you talk to your and this might be a social work situation, right? Where we say to the social worker, how can you help this mom? Maybe change to a first floor apartment temporarily in the same complex. We have done that. You have to jump through some bells and whistles, but it's worth it. And then as far as returning to work, why do you need to go to work in 2 weeks? You know, is it a financial thing? Can we help on our end to help you get set up with, again, social work to help you with some of those bills or get you a ride share or whatever. So those are, from my perspective, things that a NICU PT could do.
What would an OZ do in this situation? Just with her level of anxiety.
Me? I'll pass to Simone.
Not to say, don't do her job.
So I think the first step would, similar to what Anjali was saying, would be to get information from the mom as to why, she felt that not why she felt, but why she needed to return to work so quickly, right? Finding out what's going on. Are there additional resources that we could explore with her to find out, if there's additional support that she could get, right? For the baby and for herself as well. Doing a screening to see, what her anxiety level is. I know just because I took like a training course a couple of weeks ago, but I know that there are some inventories that are specific to postpartum health. So, doing an inventory to see like what her anxiety level is, and then, how can we help her to decrease that anxiety level as well.
Love it. I love it. I want to not neglect this particular population that I've worked with now probably more than at least 15 to 20 times. But there's a population that I feel like we need to honor whatever identity they're ready to honor at that time. But it's our moms, our birthing community that have lost their baby, that have lost either during the time that they were in the hospital during a high-risk pregnancy, had a miscarriage, whatever that loss is. And I often, go back to this scenario where the nurse didn't want me in the room because she felt like the family needed their time. And yet that was not what that mom wanted. She had delivered in such a way where she needed a walker just to get around. And her baby was still in the room. And they were bonding in the way that they could bond before her baby then was taken away. And she just couldn't walk. And her priority at that time was, yes, to bond with this child in the moments they had, but also to function. And so I realized that in our hospital systems, because we don't ask the questions that are just basic to someone's identity of who they were before they entered into that system, we just take each moment and say, well, they just had a baby, or this one, just lost their baby, or this one needs to be discharged. We don't take in the whole picture. And that's why I really wanted to get a sense of, from you all, in that case, who helps in that case? Who helps in that situation? Dr. Licotti.
So I don't have a ton of experience with patients who have lost their infants, but I will say if you do work in the inpatient setting, you're definitely going to encounter that, right? And it's going to be something that just happened at the time that they're still in the hospital. So I would say, kind of like Rebecca was saying, that you're somebody who can be in the room and be okay with being in the room and not make them feel like something is wrong with them, or like they're broken, or like their emotions are just too big for other people to handle and people need to run away from them, right? You can give them a sense that it's okay for them to feel what they're feeling and to express that in front of other people, and you're going to be able to manage that, right? You're not going to kind of back out of the room and make them feel like something's wrong with them because they feel what they feel. And also recognize that they have had a baby, they have given birth, even if they're not going home with the baby. So all of the physiological changes that occur during childbirth have still occurred to them. And they still do have the potential to have a postpartum recovery that could have lifelong impacts for them, in areas that we more traditionally think of being pelvic PT, like prolapse and incontinence and pain with sex. When they go back to that, they still have, those things could be compounded on top of their grief also, if people just choose to kind of back away from them and ignore them and pretend like all of the other things that happen with childbirth haven't happened because they have lost their infant too.
Thank you for saying that. Thank you for saying that, for recognizing that they still experience all those changes, right? I want to bring some people down to the stage with us to engage with you all, because while I have you here, we might not have the chance to talk to Dr. Middlebrooks and Dr. Arian and Simone and really just kind of like bring you all to the table with those who did show up tonight. And I want to thank them for showing up tonight. So I'm actually going to ask just a couple of you to come down to the stage and join us. I'm probably not even going to ask. I'm actually just going to bring you on because your videos are on. And so I do put people on the spot. And I ask for forgiveness later. Hello, Dr. Sylvester and Dr. Shock. How are you all? Thank you so much for joining or being voluntold to join. I would love for you to just add to this conversation. We, in this work, recognize that not every birthing person looks the same. So what we're doing as a system doesn't work for everyone. We have people who are giving birth who are under the age of 20, who are under the age of 18, who are under the age of 15, who are under the age of 14. I can keep going because these are the individuals that I've personally treated, who are 13 years old. Okay. And so we also have individuals who are giving birth who don't have all the support at home. And so we have to think of people not in these silos of whether or not, you know, they have these impairments or whether or not, you know, they're A-okay from the nurse's standpoint. We have to look at how is this impacting their physical health and the bodies that they're coming to us with, you know, to help them birth this baby. And then also we have to look at their mental health. How are they leaving us, right? Because over 98% of births, we know where they're occurring. They're occurring within these systems, and these systems are not prepared. They weren't designed to serve people the way they need to be served. So I want you to just add to the conversation in the time that we have about what impact do you want to see? What do you want to see differently within the systems that we currently have that can help our mental health? Dr. Sylvester.
Hey, thank you everybody for everything. I have more questions, I think, than answers right now, honestly. But one thing I think we should all be familiar with are grief counselors. So we've had a young girl, she was 18, and her baby died while she was delivering. So all the time she had the hope that she would defy the odds, and the baby died as he was coming out. And so no one hooked her up with grief counselors or support groups for mothers who had lost, and she was 18. But during the pregnancy, some of the things that I think that we need to start doing is thinking about those transportation issues. So she was a foster baby girl. And then I just had another mom who, her mom gave her away as soon as the baby was born. So she was thinking that she was going to give her baby up for adoption. She did not. And now she's in the foster care system at 16. And so some things that I think we should become more familiar with. I know we're not social workers, but if we're outpatient and working with these people, just what are some of the community resources that we can make available? How can they take more advantage of their insurance? I didn't know that her AmeriGroup provided transportation to and from prenatal visits. And so I'm learning so that we can connect moms with the resources that they need. And then the last thing I think about is how can we change the hospital system so that when there is loss, they're not surrounded by babies who are crying, right? So they have moms with babies who are crying and their baby is not alive. And so just thinking about how can we be more sensitive? The mom does need to stay, she does need surveillance, but what she doesn't need is to hear other babies who have successfully birthed at that time. So that's what I'm thinking about. And maybe when we said who should be on the team with this particular mom, just somebody going home with her. I think that having some home health or any provider who can come in and just be there for her to talk to. So,
Dr. Arian, that was a nod to you and to your work. And thank you. Thank you for going into the homes and meeting them where they are. Dr. Alyssa, I want to kind of highlight a little bit of the passion that you have in this area. It's such an important topic that Dr. Sylvester just brought up. We are having moms heal in environments that are triggering, right? And even being, if they need a walk in the hallway, they're just surrounded by those images. They're surrounded by that stimuli. Where do you envision our care going from here when now everyone on this panel is involved with all the ideas that we talked about?
I think, well, thank you for having me. And I echo Dr. Sylvester's comments with that surrounding. I mean, I had a mama who lost her baby, and the postpartum grief counseling was in the same entrance, had to walk by the L&D door to get into her grief counseling. And so it was a hard process. And she just said, I can't go to counseling because I can't go past that door. So that was a huge barrier for her. And Dr. Seagraves kind of knows my passion of building this comprehensive space for our perinatal group. And it starts in that prenatal education place where mamas know those resources and we give those. And right now I'm in the process of developing, what does that prenatal course need to include from a rehab standpoint? Everyone goes and does the labor and delivery, and they tour their hospital and they know the stages of labor. And if they have a doula, they're really supported. You know, we, as a pelvic health therapist, I work primarily in outpatient. I'm the only pelvic health therapist at my facility. So I'm kind of trying to dabble in a little bit of everything. I get called to L&D periodically and postpartum, and I live in rural Montana, in case anybody wants to recognize this northern accent, but on a reservation. I'm Native American. But I see this as being this very comprehensive piece that starts. And then we have those inpatient folks that do, you know, that work that is kind of missing, honestly, in my part of the world. And then that sweet spot in that fourth trimester that everybody's talking about, I think that we just are not getting the education in that before we even get pregnant. Like there's this long-term piece that we need to deal with. So I am super excited about everybody's work here, and I just see all those little networking, connecting pieces. My biggest win for outpatient therapy in my area is creating space. And that's one thing that I think, I'm a talker, I'm an external processor. If you know anything about that, we just talk all the time. But one skill that I've really honed well with my mamas, both prenatal, postnatal, all of those spaces, is to not talk and to create this space and not try to fix it. I'm a mama too, so I'm trying to fix everybody's problems and stuff. But, you know, especially with those mamas who have had loss, you're not fixing that. You cannot fix that. You are there to support and build and love. And you all know that this is a space where we cry with them. I've left appointments and I'm sobbing. And, you know, your heart just gets into it and you love these people where they are, and teach them that they're going to move on. It may not be good, but they're going to move on, and it's going to, things will change, and to create that space for them to have that change and to grieve and heal.
Thank you so much. Thank you so much for sharing that. I completely agree. I don't want to neglect what Dr. Arian put in the chat. And so kind of in this final round, I actually do want to give you all, you know, time to just remind the audience what you do, who you are, you know, in terms of just more than just your clinician, you know, identity, but who you are in terms of your values and where you see yourself and your responsibility and your role in changing the systems that we have in place that are neglecting mental health in our postpartum pregnant, even our preconceived or preconception population. So I want to give you all time, and Dr. Rose, I'll start with you because you did add to the chat about how we can do things differently, how we can see care differently.
Absolutely. So part of, when we talk about going to people's home, also some of that can be a co-treat with a doula or a lactation consultant. So having those resources that can also come to you. But yeah, what I put in the chat is I actually just learned about this recently, but stillbirth or loss doulas, people who they have the resources, they can get you through those funeral services. They can get you to how to, memorialize that loss that you've had. And they can handle the support of that. And then also give you resources to get to maybe a psychologist or someone else to then further that along, that maybe go beyond what they can do. But yeah, so just when we're talking about mental health and psychology, I'm all about mental health and talk to your psychologist. Me and my psychologist talk about our problems with, wow, I didn't know that postpartum depression could come this late after you've had the baby. And she's like, I didn't even know this happened. So just knowing that even people who provide those services learn things as they're experiencing things as well. And then it changes their services and what they can offer to you. But I offer in-home services, I offer clinic services, and then virtual, because being able to meet people where they're at, that comfort level, that just ease of access is really where we want to help people to be able to improve their mental health.
Excellent, thank you. Alyssa.
I was so distracted. I was writing down a question for Dr. Rose. I was like, oh, I gotta write that down. And sorry, can you remind me of what you would like me to say? Because I'm really—
No, I do. I want you to really just share again your vision for how this can be, not even just, we're talking about a very heavy subject, but we're looking now at a larger lens. Where can we make the most impact?
I feel like right now the most impact is empowering our mamas so that they feel like they can ask and demand the care and the services that they need. I want to talk to all the providers and tell them, oh, this is what I do, and it's so much fun, and I love talking to moms. But honestly, it's going to come from those folks who are like, you know what, you didn't tell me, and I want my next person, I want my sister, my daughter, my whoever to have that, even if we as mamas didn't have that. So just continuing to educate is kind of where, like, it's kind of like educating at home. You educate your kids and they go out and do the thing and change the world. Educating our patients that are like, God, I wish somebody would have told me. And then they spread the word. And so some of that, like a little bit of extra word of mouth is kind of where I'm hoping that we get. And women are powerful. We'll start all kinds of movements and
so you're saying going right to the moms, not just having these forums where we're talking to each other, but going right to the moms. Dr. Sylvester, speak to this, please. Better on mic.
You are so funny. We reach out a lot. So we use wearable devices to monitor moms. And a lot of the times we'll reach out and they don't even realize the mental, like how their mental stress is showing up physically. And then we teach them to journal and to meditate and to have routines and to talk things out, and their data improves. And so I think it is really making women more aware of how their mental health is impacting them physically.
Excellent. Simone.
I think also just letting the moms know that you are there to support them as well. I think that that's one of the biggest areas I would think that they probably feel that they need that support that they might not be getting. So ensuring that they feel at ease when working with you, and that they can come to you and ask any questions that they might have. If you've established a rapport with them and you may notice that something is off, then being their advocate and asking, checking in on them and seeing like, what's going on? Is there any way that I can help you? Can I help you to find resources for any difficulty that you might be facing? So I think, having that relationship with mom and letting mom know that you're there to support them, I think is a big help.
Erin, where do you see us, even where you are, changing things from the inside, from where they're happening?
So I definitely think that a multi-pronged approach is really important. Of course, talking to providers, talking to nurses, to OBs, right? I mean, they can't, nurses have been some of my best advocates, but they can't advocate for something they doesn't know exists, right? So letting them know that we're there, but also like, where'd she go? Dr. Shock was talking about really going to the source and educating moms, right? I find that working both in the hospital and I also teach community education classes on childbirth preparation and postpartum recovery for a nonprofit here where I live. And one of the most common questions I get is, why didn't anyone ever tell me this? Why didn't I know this sooner? And, I've heard stories from moms that become prisoners in their own home because their incontinence is so severe that they're embarrassed they'll have an accident, or who have given up on having sex because it's just really uncomfortable or it's painful for them. And they just thought they had to live like that as the price of having had a child. And providing education to them, especially proactively, right? While they're still pregnant or even before they consider trying to have a baby, that, these are the things that are common that you might run into, but you don't have to just live like that. I think providing education is really one of the most empowering things that we do for our patients, no matter what setting that we work in. And because we're not going to be able to give them every piece of information that we know as experts in pelvic therapy in the time we have with them, but just letting them know that if something is happening that is affecting their quality of life, they don't just have to accept it. They can reach out to us. They can reach out to other types of providers. There are resources for them out there, and they don't just have to suffer in silence or suffer alone.
Beautiful. Thank you. Dr. Middlebrooks, what would you add to that?
I definitely agree that we need to go straight to the moms. Just speaking from personal experience, I have a unique background. When we were stationed overseas, I was a patient at the hospital, I worked at the hospital, and I was also a friend of people who went to the hospital. And the moms who I ended up treating, they ended up asking their doctors questions and the doctors ended up coming to me saying, why are they asking me this? Oh, because we went over and we talked about this. And they were like, well, how come no one's ever asked me this before? Because they wouldn't know to ask. And they felt comfortable because, one, they saw me as a friend when they saw me around base. Two, when they saw me at the hospital, they realized, got it, I can trust her. And I've been able to thankfully take that same mindset, and I'm actually launching this winter, late fall, first meeting coming up in December. So excited, targeting the community of moms here, so that way they can start to prepare. Hey, these are some different things that may happen. These are some different things you should consider. Have you worked with a nutritionist? Have you worked with a psychologist? Have you worked with these different types of individuals? Because even when thinking of mental health, the reason why people don't ask the questions because they don't know what questions to ask. Like, people don't realize that nutrition can affect their mental health. So yes, I care what you're eating, not just as far as what you and the baby are getting, but if your body isn't getting the proper nutrition, your brain isn't functioning properly. And guess what? Most of the serotonin is made in the gut. I'm sorry, I'm getting ready to go on a tangent.
Oh no, we need more time. This needs to be 90 minutes. Okay.
So there's so much that goes into being able to care for that mom. And I want for them to realize either I'm the resource for you because I know people who can give you the information, or I'm the resource because I have it myself. Either way, I want you to feel comfortable coming to me, knowing that at the end of the day, I'm going to get an answer for you. You may hear me say, I don't know, which is something that most medical providers are not used to saying. And people find that refreshing when they hear medical providers say, I have no idea. Let me find an answer for you. And I have no issue at all saying that, because my goal is to make sure that you feel seen, you feel heard, and you feel valued. And if I can ensure that at the very beginning, then if something happens, you're going to come back to me. Or if something happens with a friend, you're going to say, hey, go see Dr. Dionnne. You know what? She really cared. She really wanted to advocate for me. And also, most importantly, teaching them to advocate for themselves. Unfortunately, statistics do show that when it comes to mental health, especially with pregnancy and postpartum, individuals who are affected the most are those who are low income and also have lower education. And people tend to think that because they fall into one of those categories, their voice doesn't matter, but their voice matters even much more because they're not the only person who's suffering in that situation. So if we can teach those individuals to be able to speak up and be able to advocate for themselves, I truly believe that we can start knocking down walls that need to be knocked down. But I'm going to cut it there because I can go on for days.
Well, you know what, Dr. Sylvester, how long did it take for it to come out? Waited to the end of the talk, Dr. Miller. If anybody is still in the room, if you want a part 2, go ahead and put it in the chat. Anjali, it's on you now. I don't know how you're going to top that, but you know what?
I don't know how I can be Dionnne there, but everything she said, I 100% agree with. I will say another avenue that maybe we as therapists should look at is our professional organizations, which I know many people are like, ugh, those people, but they do have some resources. And I think that partnering, so for example, the section on neurology and the Academy of Neurology, I should say, and the Neurological Society, Physician Society, they wrote their CPG for vestibular rehab together. So those are things I think that if we can encourage those partnerships with pelvic health and ACOG or whoever, or even, I mean, I even feel like we need to go to psychiatry after listening to all you guys, you know, like I think, or maybe psychology is probably a better, or both, whatever. I think that there's a lot of things that we brought up today that maybe everybody's saying advocacy, but how do we become advocates? How do you get your patients to be advocates? I have somebody, Dionnne, you were saying that, you know, maybe they don't feel as educated or whatever. We have a lot of people who English isn't their first language here. And my thing is, voting is everywhere, right? You can vote in whatever language, we will provide it, you know, like it's a law. So you can change the culture of how these laws get passed and what gets considered by your vote. If you don't want to go up and be like march on Capitol Hill or something like that, just even things like that to encourage families, parents, even your younger, you know, patients that are having babies. I think all those things, if to, like everybody's been saying, is to empower everybody to become more involved. And this is from the person who would sit back under a rock if she could all day. So I don't know. I do think I'm so glad that you guys are all part of this. And I think that we have to really fight. And it's unfortunate that we have to fight, but also from the physician standpoint, you know, they're incentivized not to send anybody out. So that's a whole nother barrier, not for today's conversation, but that's another thing that we as on this side of the fence need to consider, is that why isn't that physician, or like when I go to the NICU team and say, this mom looks like she's suffering, not my patient, not my whatever, but she's going to take care of your patient, you know. But so like that, even that, like they're butting heads, neo to OB. Why are we butting heads? You know, so I just think if we can get people to talk, and if we can even, like I learned a lot today about, I need to go back on Monday and talk to our team and say, this is what came up. I really loved what you said, Catherine, about, I mean, I never even thought about it, but those moms who have suffered a loss, being in a recovery area way, when you said that, I was like, what? So I think it's great. Yeah, so those are my.
Thank you. Thank you so much, Anjali. I really cannot thank you all enough for giving your time, giving your wisdom tonight, and really even just being ready with your beautiful selves to just be on film when you weren't even expecting, you weren't even on the panel, Dr. Sylvester, and you just came down or were brought down. But I want to end with this, and I want everyone to really be clear on my stance with when it comes to research and evidence-based practice. I'm not anti. I think I'm starting to probably have that unfortunately tied with me that, you know, well, Rebecca's not for things waiting to be in journals. That's not true. I think evidence-based practice has its place in these conversations, but I will not wait until something gets published to make a difference and to advocate. I know how long it takes to get something written and recorded. and then how long it actually takes to translate to someone who can't read, who cannot understand the information that was actually evidence-based or considered to be best practice at the time it was written. What does your journal have to do with me if I'm coming into the hospital at 16 years old with twins? I don't know that I have a voice or I can vote because I don't know who my mayor is. I have no idea who is the sheriff in my county. I don't know that I can stand up and advocate for myself and ask for this provider, because when I walk into the hospital, I see white coats and I can't tell the difference between who my doctor is or who the anesthesiologist is. So we know in this room, we need to pull together to the resources with the resources that we have, that we are aware of, but we are missing the opportunity to get on the ground and make it make sense to the people it's affecting most if we stay here. And so, Dr. Sylvester, I brought you on in this last, few minutes that we have because you are the co-host of a podcast of Operation Miss. You founded this company. You're having people come on and telling their stories. And I think it's very, very innovative and wise of you to bring their stories front and center, because that's really what changes policies, not our research journals. So thank you so much, all of you, for being a part of this conversation. I can go on. We need a part 2, do we not? Thank you. Thank you so much, Simone, Anjali, Dr. Dionnne, Dr. Aaron, Dr. Sylvester, Dr. Sharoz. I know you had to step away. Dr. Shah, thank you so much for coming and collaborating. I feel like this is a partnership. And thank you all for joining us tonight. We have part 3, and we are going to talk about how either a therapist can expand their income by doing this work, which is a work of love, but we have to start taking care of ourselves and being more resilient. So we're going to talk a little bit about expanding beyond our W-2s and our employers and really getting out and creating businesses and change that's actually helping us give back to the communities that we love and support. We're going to have that tomorrow, same time. That'll be event number 3. So I hope to see you all involved with that. I think there's a lot of you that can add to that conversation. And we're also going to talk about how moms can expand their income after they've been set back because our system failed them, and how they can bounce back even more and even expand their income after unexpected delivery outcomes. So I hope you all can join us, and thank you all tonight.